Critical Thinking and Coding Tips for Chapter 21. And our first critical thinking question for this chapter: when is it appropriate to code an incomplete abortion? Our answer: an incomplete abortion is coded when a pregnant woman has either had a spontaneous or legally induced abortion and the products of conception are retained in the uterus. It's usually diagnosed by ultrasound. However, it must be documented by the physician that an incomplete abortion has taken place. A dilatation and curettage is typically performed to remove the remaining products of conception. And our next critical thinking question: what are the differences in coding pregnancy-induced hypertension versus hypertension before the pregnancy? And our answer: preeclampsia is the development of hypertension associated with albuminuria, proteinuria, and edema between week 20 of pregnancy and the end of the first postpartum week. It can be documented as mild, which is coded to 642.4x, or severe, which is 642.5x. If the hypertension is stated as transient, code 642.3x. If the patient has pre-existing hypertension, meaning before pregnancy, that affects the pregnancy, code 642.0x is assigned. If the hypertension is secondary to renal disease that complicates the pregnancy, assign 642.1x. And our last question: when are codes 655.XX, which is known as suspected fetal abnormality affecting management of the mother, and 656.XX, which is other fetal and placental problems affecting management of the mother, used? Our answer: codes 655.XX and 656.XX are coded only when the fetal condition is documented as being responsible for modifying the management of the mother. Usually, additional observation is done and special care and diagnostic studies are performed. Just because a fetal condition exists does not justify assigning 655.XX and or 656.XX. It must be documented as affecting the pregnancy. Okay, now coding tips for this chapter. Now, Chapter 21, which is complications of pregnancy, childbirth, and the periperium, is, in my opinion, the most challenging to learn to code, but the most fun. First, you must learn the common pregnancy definitions listed on page 596 of the text. You will need to know these to correctly assign codes to this section. Next, review the main terms explained on page 600 that are used to locate pregnancy-related codes within the index. Next, new coders often become confused with what can be reported on the mother's chart and what can be reported on the newborn's chart. Think, did this condition happen to the mother or to the baby? Codes for the mother's condition are only reported on the mother's chart, while codes for the newborn's condition are only reported on the newborn's chart. Now, Chapter 21 discusses the coding of the mother, so only assign codes for services provided to the mother on the workbook assignment. Codes assigned will be from the range of 630 through 677. These codes will never be assigned to a newborn. And coding for the newborn is discussed in Chapter 22, so only assign codes for services provided to the newborn on the workbook assignment for that chapter. Okay, continuing on with the coding tips. Categories 640 through 648 and 651 through 676 require the assignment of fifth digits, which indicate whether the encounter is antepartum or postpartum and whether a delivery has also occurred. These are explained beginning on page 602 of the text. The fifth digit of 0 would rarely be used, so do not use it in this class. In inpatient cases, it's known whether this is an antepartum problem or a postpartum problem or a delivery. Now, when the patient delivers during the encounter, the fifth digits of 1 and 2 are used. When a patient presents before delivery and does not deliver during the encounter, meaning that when discharged she is still pregnant, the fifth digit used is 3. And if the patient presents after delivery, meaning during the postpartum period, the fifth digit used is 4. Fifth digits used on these codes are required to be consistent during the same encounter, so you cannot use a fifth digit of 2 with a fifth digit of 4, and etc. Now make any notes you need to in your code book to remember these uses of the fifth digit. Okay, continuing on with coding tips. When a delivery occurs during the encounter, it requires the assignment of a minimum of 3 codes. 1. The principal diagnosis, which is the pregnancy condition. Number 2, which is the secondary diagnosis of the outcome of delivery. Now codes will be from the range of V27.0 to V27.9. V27.9 is never used, so do not use it in this course. You will know if the infant is live-born or stillborn. Now, when completing the workbook assignments for Chapter 21, if the coding statement does not specify stillborn, then you are instructed to code the newborn as a live-born infant. And your third code required would be your principal procedure. It's a procedure code for the method of delivery. Now, hint, if an infant is stillborn, no file will be created, no medical record number will be assigned, no account will be created, no bill will be generated. All services provided to a newborn will be included with the mother's medical record. And continuing on with our coding tips, the use of code V25.2, which is for sterilization. This code can be used for sterilization as either principal or secondary diagnosis codes. Examples: a woman can deliver a baby and then decide on that admission to be sterilized. In this case, the pregnancy delivery codes would be principal and the V25.2 code would be a secondary code. A woman can be admitted as an inpatient or outpatient for a tubal ligation. In this situation, the V25.2 would be the principal diagnosis because this is the reason for the admission. Now, the causes of postpartum hemorrhage. It can be caused by a retained placenta, laceration of the cervix, vagina, or perineum, or rupture of the uterus, or hypotonic myometrium due to anesthesia or overdistension of the uterus due to an abnormally large fetus or multiple gestation. Treatment includes manual exploration and removal of the retained placenta and curettage of the uterus. Now, conditions that affect the health of the mother versus conditions that affect the health of the newborn. The Chapter 11 codes, which are pregnancy codes, are used to describe maternal conditions and are reported only on the mother's record, not on the newborn record. Inexperienced coders often confuse this guideline. Mothers' and newborns' codes should not be used interchangeably. Documentation must support the codes for each record. There are situations in which a maternal condition affects the newborn, but the codes will be different for each record. And the use of V codes with pregnancy. Codes V22.X and V23.X are usually used in the outpatient setting. V22X is used for supervision of normal pregnancy. As soon as a pregnancy complication or history of a complication is mentioned, the V22.X code is no longer used. V23.X, which is for supervision of a high-risk pregnancy, can be used for a pregnancy that is not normal. Now, the different stages and/or types of labor are the latent phase, which lasts from several hours up to 3 days with uterine contractions. During the first stage, the contractions come at intervals that can be painful. The cervix dilates until it's opened large enough to allow the passage of the infant. By the end of the first stage, the amniotic sac breaks. The second stage begins when the complete dilatation and effacement of the cervix and ends with the birth. The third stage of labor occurs within the first hour of birth, and the placenta is delivered. Now, problems of labor. Obstructive labor occurs if the baby is unusually large, poorly angled, has anatomic abnormalities, or has a presentation other than cephalic. Dystocia or difficult labor includes labor that fails to progress, is prolonged, or is difficult. Cephalopelvic disproportion occurs when the baby is too large for the mother's pelvis and the labor becomes extremely difficult. Uterine inertia is poor contraction strength and can lead to a prolonged latent phase. And finally, the coding of group B streptococcus carriers in pregnancy. Now, if a pregnant woman tests positive for group B streptococcus during screening, assign the codes 648.9X and V02.51. Group B streptococcus colonization, which means a carrier, does not necessarily indicate an infection. The reason this is coded is because group B streptococcus in the vaginal canal can complicate the delivery, so pregnant women with this carrier status are considered high risk.